Good evening. I'm Nancy Williams, President of the League of Women Voters of South Carolina, and I'm pleased to welcome you to our pre-lead panel presentation, Economic Incentives and Policy Options for Increasing Healthcare Access in South Carolina. This panel has been organized by LWVSC's Healthcare Working Group and responds to a groundswell of interest surrounding inequities in our state's healthcare system. Before we begin, I want to share the protocol for our Zoom meeting. All attendees' videos and microphones have been turned off as you entered. Please do not turn them back on. Only our speakers should be seen and heard. I suggest you stay in speaker view so that you can best see each speaker in any slides. This event is being recorded. That includes the chat, so please use discretion in making any comments. If you have questions for our presenters, please enter them at any time in the chat. Our administrator will collect them, and the moderator will pose some of them to speakers at the conclusion of all presentations as time permits. And now I'm pleased to introduce the moderator, as well as a presenter for this evening's program. She is Dr. Elizabeth Brown, Assistant Professor and Health Services Researcher at the Medical University of South Carolina. She also serves as the Health Policy Director for LWV of the Charleston area and is the co-chair of LWVSC's Healthcare Working Group. Dr. Brown.
Good evening, thank you. Thank you for joining us tonight. I'm excited to tell you a bit about our panel. I hope you had a chance to read their bios when you registered for tonight's session. First, I'll start the discussion and speak about Medicaid eligibility and healthcare access here in South Carolina. Next, we'll hear from Dr. Lynn Glenn, who will share her experience as a primary care provider in a free clinic and also discuss a few consequences of delaying care. Dr. Paul DeMarco will then describe his experience working for a community health center and their role in the U.S. healthcare system. Last but not least, you'll hear from Dr. Dave Keeley describe some deficiencies in the U.S. healthcare system and some potential policy solutions that promote equitable healthcare for all. With that being said, let's get started. So I'm actually going to start off first and share my slides. Okay, hopefully you can see my slides in presentation view. Okay. So just getting started tonight, thinking about Medicaid, when we talk about healthcare access and expanding healthcare access, thinking in particular about Medicaid eligibility in South Carolina. You know, what is Medicaid and what is the income limit for Medicaid here in our state? So first of all, Medicaid, and I want to make sure there's a clear distinction between Medicaid and Medicare. So Medicare is generally 65 years and older or people that have end-stage renal disease. So tonight, my portion of the talk is going to really focus on Medicaid. So Medicaid, like Medicare, was created in 1965. Medicaid is a federal and state program, so it's run by both of them. It's different across all states. So essentially what we're saying is the federal government funds Medicaid, but the states administer the program. So depending on where you live or which state you live in, Medicaid is different. I remember hearing years ago, if you've seen one Medicaid program, you've only seen one Medicaid program. So keep that in mind. So Medicaid generally covers individuals who are low income, who are disabled, and pregnant women. Now, because Medicaid is run by the states, again, it is different across different states. The income eligibility for Medicaid, it varies across states. So let's think about a family of three. Now, these estimates are from about 2017, so they may have increased or changed over the years, just a tad bit. So let's take a family of three, mom, dad, one kid. That family of three in living in Texas cannot make more than about $4,000 per year to get Medicaid in the state of Texas. Here in our state of South Carolina, that family cannot make, I think the numbers now are more closer to $13,600. So about $13,000 per year, this family cannot get Medicaid if they make over that threshold, that same family of three. So in South Carolina, a family of three that makes, let's say, $16,000 would not qualify for Medicaid. That same family of three, if they were in New York, they could make closer to $28,000 almost and still be eligible for Medicaid. So keep that in mind. So these are our annual income limits. Again, this is not per month, this is per year. And I really want you to focus on that last column. So that 3-person family, that household, $13,466 per year. If they make over than that, more than likely they will not receive Medicaid. You know, generally we hear, oh, folks can, they can just get Medicaid. When we talk about hearing about having people that are uninsured, oh, they can just get Medicaid. Not necessarily. You have to be extremely impoverished to have Medicaid in South Carolina in certain states. Now, Medicaid is more generous, at least in South Carolina, what we see is more generous to pregnant women and children, infants and children under the age of 19 years old. But because we are one of those states that chose not to expand Medicaid, a lot of people are not eligible for traditional Medicaid. So what we see as far as eligibility is generally parents, caregivers, pregnant women, children under the age of 19 years old, and certain categories of disabled individuals, so blind, being deaf. Not eligible. We have a coverage gap. We have a gap that's going on, and that is usually the adults that don't have any children in the home. They are falling into this gap. And the analogy or the picture I like to give folks is thinking about a casting net. If you're casting a net, for states that expanded Medicaid, they're casting that net much wider so that more people can be eligible for Medicaid. States that did not expand Medicaid, they're not casting that net very wide. And what we're seeing is people are falling into this coverage gap where they can't afford healthcare insurance on their jobs or on their own, and they are not eligible for Medicaid. So we need to do something and be thinking about those people in that coverage gap who are uninsured. So speaking about the uninsured, who are the uninsured in our state? What are the demographics? And even thinking about the counties, so our 46 counties across the state, what counties have the highest percent of uninsured or medical debt? So I'm going to share a little of that tonight with you also. So just thinking about the uninsured in our state, this is based on 2019 data. What we tend to see is that when we just look at the uninsured, most of them are adults, so 19 to 64 years old. Majority are white, so 51.5%, and then male. So in South Carolina, when we're thinking or talking and discussing the uninsured in South Carolina, what we tend to see is a majority of them are adult white males. So that's something else to keep in mind. We started looking at the counties, just wanting to get a snapshot, get an idea of what counties have poor outcomes regarding healthcare access and healthcare insurance. So thinking about South Carolina counties, so we have 46 counties in all. Here I've just put the top 10 counties. This is only looking at those 18 to 64 years old, because generally those under 19 can get Medicaid. Those under 19 years old can get Medicaid, and those 65 years and older can get Medicare. So thinking about 18 to 64-year-olds and the highest uninsured rates in our counties, we're seeing a lot of rural counties, which probably is not surprising. If the county name has a star by it, that just means it's a rural county. We're seeing a lot of counties that are along that I-95 corridor. So Jasper, Saluda, Horry, Dillon. Another thing to think about is the statewide average for uninsured populations in our state is 15.4%. These top 10 counties are over that percentage, with Jasper being the highest. And another reason I wanted to highlight is the highlight in the slide. You'll see these counties highlighted because they're going to show up on the next several slides over and over again. You're going to see some repetition here. So Jasper, Dillon, Lawrence, keep those in mind as I move forward through those slides. So also we wanted to take a look at the counties with the highest percent of medical debt in collections. So this is not families, but the amount of medical debt that has went to a collection agency. And on this slide, you'll notice every single one has a star by it. So the top 10 counties in our state, which are rural counties, have the highest medical debt in collections. So this is when we see a family or family member individual goes to the doctor, ER or hospital, or a doctor's office, and they cannot pay this bill. Maybe they're focused on paying the rent or feeding themselves or car payments, what have you, gas, electricity. And they cannot pay this medical bill. So what happens is it ends up in collections. So the average, the statewide share of the population in South Carolina with medical debt in collections is 25%. So we're thinking about 1 in every 4 individuals. In Union County, we're looking at 48%. So the top 10 counties are much higher than the statewide average for medical debt in collections. The last piece we wanted to share was looking at South Carolina counties with hospital closures. So since the Affordable Care Act was passed in 2010, we wanted to see what hospitals we've lost across the state. So these again are our rural counties. Marble or Barnwell have also popped up in other tables that I have just shown. But if you look at the number of beds that we've lost, so thinking about estimated 200 beds that we've lost with these hospital closures, but also thinking about the ripple effect of jobs lost, services to the rural communities, elderly, low-income individuals that have lost these services and these beds in these areas over the last 10 to 12 years. With that, I'm going to just share a few resources for health insurance and healthcare, and we'll make sure that we make these slides available for anyone that's interested. If you're interested in learning more about Medicaid eligibility, Federal Healthcare Network, or federally qualified health centers that help see underserved populations, we have that information here. Here are some resources, and I'm actually going to stop sharing and turn it over to Dr. Lynn Glenn now.
Good evening, everyone. We do not have snow yet where I am, but hopefully everybody is safe and warm where they're at. And let me share my slides here. Okay, so as the introduction informed you, that I'm a boots on the ground nurse practitioner. I've worked for several years in South Carolina, and actually the first job that I had was a family practice in Bamberg, South Carolina, where we did have a hospital closure in 2012. So I definitely have seen that personally, experienced the just really huge impact that had to the community of the hospital closing. So I'm just going to provide just kind of a bird's eye view of what it's like to provide care to the uninsured in South Carolina. I'm sure that it's different from county to county, state to state, community to community, but I'm just kind of sharing just my personal experience. So I've been a primary care provider in the rural community in South Carolina for several years, but for the last 5 to 10 years, I've exclusively worked with the uninsured population. So I can kind of compare the two of what are the pros and the cons of working with the uninsured population. So the advantage in working with this population is that I don't have to deal with the insurance companies. And I think anybody who has insurance knows how difficult insurance companies can be, whether you're a provider or whether you are the, the patient. It's extremely complicated and extremely frustrating. So the good part of my job is that I don't have to deal with that part. The uninsured come in with a lot of social issues. They're kind of in some tough life circumstances. And so the part that I really like about providing care to this population is that I can kind of address the social determinants of health in their visit when they come. And often when you provide care in a private clinic, you don't have the time to address those issues. So I've really enjoyed trying to address some of those issues and providing care. It provides more flexibility and autonomy in that job, using problem-solving skills and trying to learn community resources. So basically, I became a social worker by trade. I had to Google and find where the resources were in the community. Oftentimes, these patients really don't know where to find help. And so we just kind of partner with them and try to figure out where we can find help for them. In the clinic that I worked in, I saw a lot of patients that had chronic care conditions such as diabetes, high blood pressure, that sort of thing. And so I saw them on a regular basis and got to know them really well. And that is a satisfying and rewarding experience to really get to know people day after day and year after year. I really did enjoy that part of it. So of course, there's disadvantages in dealing with this population. And the most frustrating thing is there is an inequitable care to this population. Limited access to care and treatments and surgery and so on and so forth. So a big part of my job was being the patient advocate. So when I first started working at the free clinic in Orangeburg, the hospital had a charitable care program where most of the services were waived and they were not billed for those services. But over time, and then when the Affordable Care Act was initiated, a lot of those funds for charitable care was cut. And so we kind of had to negotiate with the hospital how we were going to pay for those services. So that took probably at least a couple of years to negotiate that. And really all we were able to negotiate was a reduced discount rate for specialty care. We weren't able to negotiate any discounts for x-rays or any kind of surgery or any kind of treatments. If they needed an ultrasound or a CAT scan, they did get a discount, but it really was not affordable for this type of patient. And like I said, they come in with a lot of life situations that they're really unprepared for. A lot of them have lost their job and really had a crisis situation and really had a hard time getting through that. The good news was that providing healthcare was one less burden that they had to worry about. So that was helpful to them. They could focus more on other things. Primary prevention is really how we can cut down healthcare costs and make people healthier. But that was not always the priority for these patients. So the issue that I really want to bring up, and I think Dr. DeMarco can certainly add to this conversation, is if we don't ever get to universal health care legislation, then how are we going to sustain health care to this population? So again, I've mainly had experience in free clinics that provide charitable care. We don't charge those patients anything when they come to the clinic. So we are actually providing a lot of cost savings to the healthcare system. So they estimated in South Carolina in 2019 that we saved $120 million of direct care to this population. Go ahead. Oh, I think if you could mute, that would be great. So most of the services are provided by volunteers. I did get some compensation for my services, but it was not, equal to a regular job. There's a lot of contributions and donations that are made to these free clinics. For example, in Beaufort County, which is a very wealthy county, they had over $6 million in donations in 2019. Now, where I worked in Orangeburg, we're not quite as wealthy. We got about 100,000 last year in contributions. And we were able to sustain our services during COVID. But I'm not sure of how long we can sustain this, and we can't really depend on contributions day after day and year after year. And it's very variable across counties and across communities. Again, like I said, the only discount we were able to get with Orangeburg Hospital was an $80 visit fee for specialty consultations. We have a large monthly bill to do lab work, which is very important in providing care. And again, like I said, there is a loss of funding for charitable care through the Affordable Care Act. So a lot of these patients delay their care, which has many long-term consequences. A lot of them are ashamed to come for free care. A lot of them are ashamed to seek care because they're embarrassed that they can't pay the bill. A lot of them are afraid to miss work because they might miss wages. So a lot of them delay care because of that. And so the delay in care causes a delay in treatment, more healthcare costs, and more healthcare consequences. So during COVID, there was a lot of delay in care. Over almost 50% of the people postponed care during the pandemic. And I'm just going to kind of point out a couple scenarios really quick about some patients that I took care of. I had one good story and one bad story. So I had a lady who was about 50 years old who came in with symptoms of uterine cancer. She had some bleeding. And it took almost a year of repeated phone calls to get her a consult and get her surgery done. So that year caused a delay in her surgery. She ended up doing really well, but she needed radiation treatment for her cancer, which if she had gotten diagnosed very promptly, she probably wouldn't have required that radiation treatment. So kind of a sad story. I had another patient who had elevated prostate cancer levels in his blood, and he waited several years to kind of follow up on that. And by the time he got diagnosed, he had metastatic prostate cancer. And we really don't know all the reasons why that he delayed his care. But a lot of it was, I think, he was very embarrassed that he could not pay the bill. And at that time, the urologist was not working at the hospital. He had to pay out of pocket. So unfortunately, this gentleman died, but the delay in care, cost his life, unfortunately. But we tried the best we could to get him into care. So, like I said, I've really had to work at trying to find the resources for these patients. If you're interested and you know anybody who does not have insurance and needs a healthcare provider, the South Carolina Free Clinic Association has a website. We have over 40 clinics in South Carolina. Well Vista is a pharmacy in Columbia that provides free prescriptions for these patients. GoodRx has discounts. Best Chance Network offers free mammograms and pap smears for women in South Carolina. And then South Carolina Thrive kind of is an umbrella organization for anyone in South Carolina who has a need for resources, whether it's help with taxes or help with insurance and just a variety of different things. So they're a very good organization if anyone needs help with their circumstances. So I could talk for a very long time, but just I think it's been a privilege to represent and try to advocate for this population. We really need equitable health care. We do need universal health care, but really what we need is equitable health care. Health care should be a right and not a privilege. So I will turn it over to the next speaker, and thank you for letting me share my experiences.
Good evening, everyone. I'm Paul DeMarco. I'm a general internist. I work at a community health center, and I've got some slides that I will share with you. Oops. There we go. All right, you just went through them backwards. So thank you to Dr. Brown and Dr. Glenn for their presentations. I think this webinar will flow very well with Dr. Brown's presentation about Medicaid and Medicare, and then Dr. Glenn's presentation about free clinics. My role is to talk about community health centers, which, if you're not familiar with community health centers, they are a really useful public-private partnership. They are subsidized by the federal government, but they're also run like a business. So you need both the public and private sectors working together to have these clinics work and be survive economically. So they're not just purely government run. And it works very well. And because of that public-private partnership, there's a lot of bipartisan support. They're very protected politically. There are about, well, before I get into the numbers, let me just go over this slide. So it's a public or private nonprofit healthcare organization. But again, there's usually both a public and private entity or part of each one of these. One of the interesting things about community health centers is this bullet right here. They're governed by a board with a majority of the members of the board of the community health center are patients in the community health center. I work for one in Florence. It's called Hope Health, and my office is at Francis Marion University, so we're called Hope Health at Francis Marion. And besides the primary care that we provide, Hope Health provides a range of other services. We started as an HIV clinic back in the 90s, and so have a very strong HIV/AIDS component. We have several infectious disease doctors that are on our staff, and a very robust case management for HIV patients. We have dental, we have a strong behavioral health component. We have several psychiatrists. We have substance use disorder treatment, including Suboxone, and as well as pain management. We have 2 great endocrinologists. We have 2 rheumatologists, so it's not just primary care. And many other community health centers do have specialty care. We have women's health, chiropractic, radiology, pharmacy. So it's a multi-specialty group. Here are the stats. Here's who we serve. There are 1,400 clinics across the country. You may hear the term federally qualified health centers. Most FQHCs are community health centers. There are some other entities that can be FQHCs that are not, but basically we're talking about community health centers. You probably know of one. There is one or more in every county in South Carolina. Well, actually, there's not. There's one in about every other county in South Carolina. But we have one in Florence, one in Marion, where I live, one or two in Horry. And they serve a significant number of patients. And I think one of the questions I was asked to address is, if we go to a universal healthcare system, if everybody gets insurance, how are we going to serve those people? And free clinics could be retooled in order to serve a certain number of those patients. But community health centers are really in position to serve a significant amount of new patients. We have capacity. So I've been thinking about working for David. Dr. Keeley can tell you that I've been interested in this topic of universal healthcare for decades. And so I'm ready. Here are the people that the community health centers serve. So about 1 in 10, 1 in 11 people, 30 million out of 330 million in the US, more than 1 in 10 children, 1 in 7 racial or ethnic minorities, about 20% of uninsured patients, and about 33% of people in poverty. We serve some special populations, those who speak a language other than English, those who live in public housing, those who are experiencing homelessness, and that is a particularly difficult, complicated group of patients to care for. Imagine if you're a diabetic, well, you need to refrigerate your insulin. That's hard if you don't have a home. Agricultural workers, school-based clinics are a really interesting way to deliver care and can work really well. And then veterans, along with the VA, of course, takes care of most veterans, but we have some. I have several in my clinic. So as you would imagine, we serve a lot of low-income patients, about 90%. But one of the things I want to reinforce to you tonight is that community health centers are not just safety net providers. We look like every other doctor's office, and I'll show you a couple of pictures of my office that I took just 2 hours ago. They're hot off the press. And I have some high-profile patients, people whose names you would know, even if you don't live near Florence. You've heard of some of the people that I take care of, because what they've figured out is community health centers are a great place to get care. Most of the people who work in community health centers work there because they really care about people, no matter whether they're rich or poor. And they also don't need to make the most money they could possibly make. And they're not pushed to see an enormous number of patients. You know, you've got to see a good many, but it's not a mill. And so it's a great place to deliver care. So if you are looking for a primary care provider, don't rule out community health centers. It is a good option for anyone. Our payer mix is different. There's about a quarter of our patients are uninsured, as opposed to less than 5% in a typical private practice. And our patients are sicker, but that just means we're that much better at taking care of complex patients. We are cost effective. We save 24% per Medicaid recipient, 10 to 30% with Medicare, 35% per child. So our care is cost effective, and our results are also better than average. So if you go to a community health center, you are more likely to get a routine checkup and a flu shot. You're more likely to visit the doctor. You're more likely to be satisfied with your care. And uninsured patients who have all the barriers that Dr. Glenn elaborated on, difficulty with transportation and more complex family dynamics, all those health maintenance items, mammograms, pap tests, colorectal cancer screenings, are all more likely to happen if you're at a CHC. And so here's my office. And I took these pictures not because I wanted to impress you, but because this looks like any other doctor's office probably that you've ever seen. So this is what we do. There are my references. And I just wanted to, before I hand it to Dr. Keeley, I wanted to talk quickly about why community health centers, or where we still fall short. So community health centers provide access to everyone. If you make zero income, we have a sliding scale. And that's why uninsured patients come to us, because when you come to that window and you say, I don't have any insurance, we don't say, well, that'll be $200 up front. We say, okay, we can handle that. We lean into uninsured patients. We say, here, we've got a sliding scale. If you make no money, the most we're going to charge you is $20. And that includes anything that I can do in the office. EKGs, lab work, pap smears, anything that is done in the office. The problem is when I need to send you out. And so I'll leave you with this one example of a, this is one of many significant holes in our system. So if you have insurance and you come to me and I say, listen, you're 50, you need a colonoscopy, your insurance is going to cover it. If you're not insured, you're facing a $10,000 bill. My colonoscopy that I had a few years ago, my bill was just short of $10,000. Now I paid a few hundred, but patients who don't have insurance have to pay the full price. And so therefore, I've never had a patient without insurance say, I still want a colonoscopy. And even patients who have bleeding, I have a really difficult time. There is a program in South Carolina called the Colon Cancer Prevention Network, but it is very, very difficult to get colonoscopies. So that's one of many examples I could give you of why we need a universal healthcare system in this country. And Dr. Keeley will now tell you just how far behind we are in the United States.
Thank you, Dr. DeMarco. And I'm pleased to have the opportunity to join in this forum. As you may or may not know from reading my bio, I as a family medicine and public health physician for 40 years in South Carolina, have, like Dr. DeMarco, come to the conclusion that we need to move as rapidly as we can to a universal coverage system. So what I'm going to do is to make sure, Paul, I think, can you let me, I need to share my screen. Let's see. Oh, there we go. And okay. What I'm going to do is give kind of a build out the foundation of information that that Dr. Brown presented, and give some further context to the situations that Dr. Glenn and Dr. DeMarco described. And what I am also going to do is try to leave you with some suggested courses of action in the policy arena. So let's get on with it. And let me make sure, let's see that, there we go. So we have in South Carolina, we pack stadiums with people. Here's Clemson's Death Valley, and South Carolina's Williams-Brice Stadium. Look at all those people. Why am I showing you these? And if you look at the top part of this slide. I'm showing you because the actual number estimates that have been referred to in terms of 18 to 64-year-old South Carolinians, we have 335,000 uninsured in our state, and that would be filling Death Valley 4 times over, and that's a lot of people. And as far as the underinsured, now as has been referenced, there are folks who fall in and have an opportunity under the Affordable Care Act to buy into insurance exchanges, or they might have a limited coverage offered by their employer. And so we call those people underinsured because they struggle with paying deductibles and copays, and even, again, delay and care like the uninsured. And we have so many of the underinsured people in South Carolina that we would fill Williams-Brice Stadium 7 times over with 556,000 people. So just under 1 million South Carolinians are in a category to struggle. If you look at the bottom part of the slide, you can see where those who are covered, where they fall. We have a little less than half of our population with employer-sponsored insurance, and people might think, that we have a lot of Medicaid, but really we're right at the national average with about 16%. This non-group would be the people who are on the ACE Affordable Care Act menu plans. Let's advance the slide here. I did want to just mention quickly that in South Carolina, we have a lot of small businesses with fewer employers and fewer employees. And look at the difference in the availability of employer sponsored contribution in health insurance compared to larger employers. So this is another explanation of why we have people who are struggling in our state and delaying care. Dr. Brown mentioned the coverage gap, and here's a graphic to show you in red, under 138% of the federal poverty level. You see childless adults are fully in the coverage gap. About 50% of low-income families are in the coverage gap, and a smattering of age blind or disabled are in the coverage gap. So that's what we're talking about when we say if we expand Medicaid, like many other states have done, we would eliminate this red area. As was referenced by our primary care speakers, access to care, health outcomes, financial security, economic mobility, and reducing uncompensated care are all benefits of expanding Medicaid. And in my references, I have there's a document that you can read further about these specifics here. And then, as inferred by Dr. DeMarco, lives will be saved with people getting regular checkups, early stage cancer diagnoses, being able to get their prescriptions filled on a regular basis, and getting surgical care, in a timely manner. So, for the balance of my presentation, I'm going to try to really give you a picture of our U.S. healthcare system, and I want you to keep these 7 key words in mind. What we should be striving for. These are in alphabetical order, no particular sequence, but universal is the kind of, you could say, is forming the base, and then we want it to be sustainable, high quality, equitable, efficient, accessible, and affordable. So keep those 7 key words in mind. So what about our healthcare system in the U.S.? Where do we stack up in relation to 10 other industrialized advanced societies? And if you look on the right-hand side, you can see that the U.S. is the bottom in the overall rankings, except in the care process. So when we get people into care, that's good. But we have so many people who are delaying care or can't get into care. That's leads to other bad things. If we compare the performance on these parameters, you can see the U.S. is well below the rest of the nations in terms of the performance indicators. Cost. Look at the spending. The U.S. is at the top with 16.8% of our GDP, and that's probably more. This is 2019 data. I've heard estimates up at 18%. But you can see we're just separated from the rest of the group. Then if you look again at healthcare spending as a percent of GDP in the country, we have a big GDP, but we also are spending just way out of line by comparison to these other countries. And then, just the systems in the 11 countries, when you're looking at higher performing versus lower performing, again, our indicators leave us at the far end of the curve. As far as cost, we can see that the light colored dots are lower income folks, and they are in the U.S. reporting very significant differences in terms of being able to access medical care. And this is 2020 data. And uninsured non-elderly adults, like we've referenced, the 18 to 64-year-old group, if you look just at within our country over the past 15 years, how the underinsured and the percentage of continuously uninsured has continued to climb, and the number is at the 27 million range for the country for underinsured. I've checked, and that number may be even higher at this point. COVID, remember, these data that we're giving you are pre-pandemic. So I think that gives you what's happened with the pandemic to lower income households and the underinsured. So what about the over 65 group? What's been going on in our country with Medicare covered folks? over the course of time, you can see that the ranking of shorter lives and poorer health for the under 65 group continues to be low compared to other comparable countries. But what happens over 65? Look at that. We have men and women whose measures of better health and longevity significantly turn upward with the advent of eligibility for Medicare. So that leads to a lot of healthy seniors and happy seniors. So again, considering what I just said about the U.S. healthcare system, we are not accessible. We're not affordable. We aren't efficient once people get into the system. We're not equitable. We do have, again, high quality for the most part for people who have adequate insurance, and we just don't have a sustainable, with the costs going up, percent of GDP, it just does not appear to be sustainable. So let me leave you with these 5 suggested policy options. First is as Dr. Brown mentioned, South Carolina Medicaid, at the state and or federal level, action needs to be taken. And this would move us to be a more equitable and move us once, that's, a good, important step toward universal coverage. Negotiate prescription drug prices. This requires federal level action, but it is a big factor for a lot of folks with lower wealth households. And if we negotiated prescription drug prices like is done in the VA system, in Medicare, we will have much more equitable care. Delinking employment and health insurance benefits. This is something that, I can give you a scenario, but in the interest of time, what is important there is that employment since the 1940s, health insurance benefits have been added to try to retain or attract employees. But at this point, we don't need that. And as we found with the COVID pandemic, when we have so many people losing their employment, then all of a sudden they're out in the cold as far as health insurance coverage. Number 4, improve and expand traditional Medicare. This requires federal level action, and in the process of achieving an expanded Medicare model, it would include eliminating the coverage gap in South Carolina and Medicaid. It would include negotiating prescription drug prices and delinking of employment and health insurance benefits. And there is legislation that thank you. So finally, all of this is going to require campaign finance reform. And that's the big challenges there are the health insurance industry, pharmaceutical industry, and large hospital systems. You can learn a lot more about these 3 factors. The reference for these videos is in my references. And if we can achieve an improved and expanded universal healthcare system, we will have a lot of people of all ages smiling and showing appreciation. Let me leave you with the historical important quote for Dr. Martin Luther King from the 1960s. injustice in healthcare is something that we should not be tolerating. Thank you again, and I'll turn it back over to our moderator. Thank you again.
Thank you. So I do realize it is 7:58 and we did plan to end at 8 o'clock. So if you need to leave at the top of the hour, that is fine. We understand. We are going to hang on for a few minutes to answer some of the questions in the chat. So the first question that came up from Janet Marsh is, are seniors in nursing homes covered if low income? So I'll try and answer some of that and then shoot it to another panelist. So seniors, so 65 years and older, are eligible for Medicare. If they are also deemed low income, they can also get Medicaid. So they would be a dual eligible patient or individual. So they would have Medicaid and Medicare. The nursing home piece, I believe that still applies, but Dr. Keeley, Dr. DeMarco, or Dr. Glenn, do you have anything to add on to that?
No, I agree with what you said, and with nursing home, the long-term care feature of South Carolina Medicaid kicks in. But there is something called spend down that families do have to spend down a certain amount of their resources. That has to happen.
Okay.
And as well, there's a limited supply of nursing homes that accept Medicaid eligible patients. So typically it's very difficult. They're on long waiting lists. And as you saw during the COVID epidemic, some of those are lower quality nursing homes, and really kind of a devastating thing for that population.
Okay. The next question was, what percentage of uninsured received the COVID vaccinations or COVID testing? What percentage of the uninsured received COVID vaccinations or COVID testing? That is from Barb Hams. Dr. DeMarco or Dr. Glenn, would you like to try and answer that one?
I have no idea.
Yeah, I don't know what the percentages are either. That's a very good question. From my standpoint, we had a really good uptake of vaccinations for COVID. It was free. And the COVID testing usually is free depending on where they go, especially now the Postal Service is providing free testing. So the vaccination uptake was good in our population. I don't know what the percentage is, though.
I don't know percentage either, but our public health system did its best to make, and in certain communities partnered with the hospitals and public health systems to make vaccination clinics very accessible. So, some of it came down to just the individual trusting whether this new vaccine was something they wanted to receive.
Yeah, and I'll just add to that, the local pharmacies that we deal with are really probably our biggest supporters of uninsured patients. They have been fabulous in trying to work with us in, getting the prescriptions that these patients need. So support those local pharmacies. They really are important in our communities.
Okay. Next question. Do you provide mental health services? So this may have been when Dr. Glenn was speaking, but I'm going to pitch it to both Dr. Glenn and Dr. DeMarco. Do your facilities offer mental health services?
Go ahead, Dr. DeMarco.
All right. So one of the things that I love about community health centers is that they really have made behavioral health a cornerstone of their treatment. So I have a small office. It's me and two other nurse practitioners. But about a year ago, Hope Health put a full-time counselor in my office. It's that important that we had someone full-time. So our community health centers, and I think most of them around the country, are making a concerted effort to add behavioral health care to our services because it's just such an important part of providing good primary care.
So every county has a mental health clinic. And so where I work in Orangeburg, they have a mental health clinic that uninsured patients can go for no cost to them. It's a very inefficient system. Sometimes it's, offers good mental health care, and sometimes it doesn't. So I think when there's a crisis, that's when we really have issues with our population. But every county has mental health services and also drug and alcohol abuse programs as well for the community. And that's state funded, federally funded as well.
I can say that there's an inadequate supply of child psychiatrists in South Carolina, and then there's maldistribution of psychiatrists. Rural areas, it's more of a challenge. But as Dr. DeMarco has made a great case, community health centers more and more are making good quality mental health counseling services available in rural areas.
So the next question I see, so we talked about, hospital closures and rural counties having a huge impact with the uninsured. So this question is, I'm going to field it to Dr. DeMarco. Are community health centers filling the gap created by the decline in rural hospitals?
I don't think that's really our role because we only provide outpatient care. So, and I'm near enough to the Marlborough Park Hospital to have felt the reverberation of that hospital closing. I think that was the only hospital in Bennettsville County, in Marlborough County. And when you lose a hospital like that in a rural county, it really hollows out your infrastructure. It's usually one of the biggest employers, and they're good jobs, usually with benefits. It's harder to recruit industry. So I don't think that community health centers are going to be able to make up that gap. There are some hospitals that have urgent care centers or other outpatient services that they provide, and community health centers can do a little of that, but really the services are different. And so when a patient needs to be in the hospital, a community health center can't serve them.
With the that just to expand a little bit on the idea of hospital closures that Dr. Brown mentioned, that with a more universal healthcare insurance coverage, these smaller hospitals will be able to sustain much better. So we could potentially prevent future closures by moving more rapidly to a more universal coverage.
I have one more question and then a comment. So the question is, if the Medicaid gap was eliminated, would there be enough providers to accept Medicaid patients, additional Medicaid patients, and would more community health centers be needed? I'm going to field that to Dr. Keeley.
Yes, thank you. The legislation that has been proposed at the federal level to address expanding Medicaid and to improve and expand Medicare actually has a full component that calls for increased training of primary care providers. That would be of all levels, mid-level and physician. And so there is a need for more primary care providers, and if it's a stepwise process where Medicaid in South Carolina gets expanded before we have more general universal coverage, there will be some issues about reimbursement and whether some physician practices will expand the percentage of patients that they accept with Medicaid. So that can be a difficulty that we'll need to talk about at the state level.
So the last piece.
Can I add?
Go ahead, Dr. DeMarco.
Dr. Brown, can I add something real quick? So when I joined Hope Health in 2011, so it's been 10 years, we had 10 providers, and now we have more than 100. So what that tells me is that community health centers are able to grow, and I feel very confident that community health centers will be able to meet the need. I think there would be some lag, but community health centers are robust and nimble organizations. So based on the growth that I've seen in the past decade, I think we could do that again. We've opened up multiple new sites, several very rural areas like Greeleyville in Williamsburg County. So I'm not worried that we couldn't meet that need.
Okay. The last piece is a comment, and I'm just going to try and summarize it. So this individual was saying, vision and dental care data and those needs would add a fuller picture and support this thesis of inadequate coverage and access. So thinking about dental and vision needs. And she mentioned that a one-day free medical clinic around the state have people waiting in lines overnight. Very common procedures in these clinics are tooth extractions and eye care. And with that, I think all the panelists would agree to that, vision and dental issues as well. If anyone is interested, this did not happen in our state, but I would encourage you to Google Diamante Driver, a 12-year-old individual. Look up his story and learn how delaying access to care can truly impact people. Diamante Driver, a case that happened in 2007 with dental care. So with that being said, I'm actually going to go ahead and wind down. Thank you for staying on. I'm going to share actually our contact information just in case others have questions, they want to reach out to us, let us know. And I think we're going to try and get that contact information in the chat as well. So thank you to each one of our panelists for taking time to share your expertise with all of us tonight on such an important topic. We encourage each of you to continue advocating for the uninsured. Continue asking questions, keep the conversation going until every South Carolinian has access to affordable and quality health care. Thank you for joining us tonight and have a wonderful evening.